Yes,
Yeah,
sir.
thank you very much. My topic is the role of CABG in congestive heart failure. This topic is particularly important because I was just listening to Dr. Anvay Mullah, my friend, especially in the context of the current situation in this country where multi-vessel PTCA is widely available, CABG is widely available, and a large number of heart transplants are being done. This question is no longer of theoretical interest, but of great, profound practical importance, because when you have a variety of therapeutic modalities available, it becomes important for us to be able to clearly define which category of patients is likely to benefit from which particular approach. And if we are going to be able to do full justice to what is available in the country. And I speak from a position where we have now done close to over 400 isolated heart transplants for various indications. So heart failure, the topic is a role of CABG in congestive heart failure. Now, congestive heart failure is a clinical entity where you need to clearly define what criteria you're using for congestive heart failure to be diagnosed in a patient. Congestive heart failure, in my opinion, cannot be equated with symptoms of mild breathlessness or angina equivalent, or flashes of elevated LA pressure with some pulmonary edema, which can be a surrogate for ischemic episodes with preserved ventricular function. Congestive heart failure also does not capture patients with ejection fraction of, say, less than 40%, who are otherwise good condition without evidence of congestion, either of the left or right side, where renal function and other functions are well preserved, where there is no orthopnea. So congestive heart failure connotes a situation where a BNP is raised, where there are overt signs of heart failure with elevated left atrial pressures on the left side, maybe elevated pulmonary artery pressures, or certainly elevated diastolic pulmonary artery pressures, and in more severe cases, increase in right atrial pressures with evidence of right ventricular dysfunction. So the role of CABG in that kind of a situation becomes much more complex to define and to dissect out the possible benefits that revascularization can have in that context. Especially, you have to remember that each of these procedures is expensive in the context of modern India, and a patient with limited resources cannot be spending for repeated procedures every couple of years. So it becomes important for us to be to be able to advise the right procedure at the right time. So heart failure can be with severe left ventricular dysfunction, or it can be diastolic heart failure. The diagnosis and the approach to heart failure becomes easier if there are mechanical problems like severe mitral incompetence, especially if the mitral incompetence is because of a clear mechanical rupture of a papillary muscle or a chordae tendineae, where the role of CABG along with possible mitral repair or replacement becomes less controversial. And of course, in patients with isolated ventricular aneurysms, which is resectable with a good, nicely functioning rest of the myocardium, which has revascularizable vessels and which have shown viability, the role of CABG becomes less problematic. The issue is, of course, we have to be able to demonstrate viability of the myocardium by using whatever methodology that is currently available. And we really have a choice of, as compared to even 15 years ago, apart from thallium, we now have MRI and we have PET and we have so many other modalities of diagnosing viable myocardium. And if the amount of fibrous tissue is not profound and the targets are reasonable and is a multi-vessel disease, revascularization can be expected to have some beneficial outcomes. It's also often made a distinction between preserved ejection fraction and reduced ejection fraction in the literature, except that in real life, quite often, you can have the commonest presentation can be a mixture of both. You can have a patient with ejection fraction, which is around 35 to 40%, but where there are signs of diastolic dysfunction. where there are signs of elevated left atrial pressure or elevated pulmonary artery pressure, and where the BNP is high. And these are the kind of real-world situations where we are confronted with diagnostic and therapeutic dilemmas. The number of PubMed citations has really enormously gone up in the last decade for diastolic heart failure, and the prevalence is, of course, much higher because of increased awareness of this. And the applicability of CABG as a therapeutic modality is based on differentiating heart failure into preserved and reduced ejection fraction. And there is this Venn diagram shows there is a gradation between diastolic dysfunction, diastolic heart failure, and heart failure with preserved ejection fraction. And several studies have shown that the incidence of diastolic of coronary artery disease can be very high as 40 up to 50%, both if you were to investigate them aggressively, even in patients with preserved ejection fraction. So if the coronary artery disease is present, the rate of decline of ventricular function is exaggerated. So a patient can present to you with coronary artery disease with preserved ejection fraction, and over a period of time, this can degenerate into reduced ejection fraction. And there have been several publications. So this particular modality is often underdiagnosed, and the prognosis of patients with both reduced and preserved ejection fraction is considerably worse in the presence of severe triple resistant coronary artery disease as compared to patients without coronary artery disease. And there have been several studies now looking at 10 years of data. And as you can see, the cardiovascular death mortality between preserved and reduced ejection fraction is not substantially different, 63 versus 70% as compared to no coronary artery disease. So underlying coronary artery disease is a very important risk factor for patients with both preserved and reduced ejection fraction, and can be a major cause of death in both of them. So the decision regarding CABG versus multivessel PTCA should be decided by the anatomical factors in a given patient. What is a type of coronary artery disease? Are the targets revascularizable by surgery or by angioplasty? What is the syntax score? And most importantly, from the point of view of surgery, because I'm speaking on CABG, what are the additional risk factors? Your patient can have an excellent targets. He might be a great candidate, he or she might be a great candidate for surgical revascularization, but could have had a history of previous strokes, could have severe carotid disease, could have severe peripheral vascular disease, could have severe renal dysfunction with the creatinine of 1.5 and 2. And under those circumstances, the risk of revascularization has to be taken into consideration, considering the perioperative morbidity and mortality. And in general, the presence of coronary artery disease increases the risk of death in the first 30 days in the first 1 year. The role of drugs in heart failure with preserved ejection fraction has not been very clearly defined, with no significant apparent outcome. And so they had to target the comorbidities. And if there is coronary artery disease, revascularization has shown a very clear benefit over non-revascularization, as you can see in these Kaplan-Meier curves, both in single vessel disease and multivessel disease. And especially in moderate to high syntax scores, revascularization has very clear benefits. So our current approach is, especially because we have an option of transplantation possible and with excellent outcomes. In fact, our current 5-year survival rate of transplant is in excess of 78% with excellent quality of life. So we would revascularize if there is a very clear-cut evidence of ischemia. So if a patient is referred for treatment of heart failure, and you put him or her through an algorithm of BNP, of VO2 max, detailed echocardiogram, detailed assessment of myocardial viability, including with dobutamine stress, with MRI, and with PET scan, and an angiogram. And if there is a clear-cut evidence that ischemia exists, which is reversible with revascularization. And depending on anatomical and other factors, if a patient is suitable, certainly a multivessel CABG is indicated under those circumstances. My own thoughts on this: right ventricular dysfunction seldom improves with CABG. So if you have a patient with a CVP of 20, with peripheral edema, with signs of right-sided congestion, with pedal edema, low albumin, in general, CABG is never going to be of long-standing benefit. These patients are better treated with other modalities of treatment. If there is end organ dysfunction, especially if the creatinine is high, yeah, I'll finish. And there's peripheral vascular disease, the risk increases. And you have to keep in mind that any CABG at this stage, including with blood transfusions, may increase the risk of future transplant if unindicated surgery is done. So in conclusion, in the current era, with widespread availability of multivessel PTCA surgery, transplantation, and MitraClip, and perhaps even percutaneous mitral valve replacement, the best approach to patients with heart failure, with coronary heart disease is a multidisciplinary team approach where every patient is discussed on an individual basis and the best possible decision is taken, which is in the best interest of the patient. Thank you very much.